Good evening, everyone. I am Alaa Sobhi, lecturer at Women Imaging Unit. It's my honor to be with you to speak about the artificial intelligence. This is a talk of this era, especially its role in detection breast asymmetry. First of all, will AI replace radiologists? What's your opinion? Okay, we will answer this question at the end of the session, inshallah. What is the asymmetry? When we want to describe any lesion in mammography, we refer to mammography lexicon. The lesion may be one of the three mass architecture distortion or asymmetry. The asymmetry have 4 types: asymmetry, global, focal, and developing. When the arrow go downward, the risk of malignancy increases. First type, the single view asymmetry. It is the possession of fibroglandular tissue seen only in one view. In case there is left upper area of asymmetry seen only in the left MLO view. In most cases, the cause of this asymmetry, it is summation artifacts caused by superimposition of normal breast structures. The global asymmetry, it is occupying larger area of breast tissue, more than at least one quadrant. It is always represent normal variant, but it occasionally may indicate underlying breast cancer if it is corresponding area of palpable abnormality or associated suspicious microcalcification. Focal asymmetry, it is only seen, it is seen in both views, but occupying less than one quadrant, as in this case. There is left upper outer quadrant area of focal asymmetry. The last type, the developing asymmetry. It is a focal asymmetry, but either larger or denser than previous. So the previous imaging are essential to compare. In absence of hormonal stimulation, trauma, surgery, infection, the risk of malignancy is high, 13 to 27, for the developing asymmetry. Okay. How AI software express and detects the abnormality, either qualitatively through heat map or quantitatively through one of both. Probability of malignancy, it is a scale from 0 to 100, 0 definite non-cancer and 100 definite cancer. Or through likelihood of malignancy, it is also another scale from 1 to 7, 1 definite normal and 7 high suggestive of malignancy. Here we will discuss the value of AI in diagnosis and detection. What is the beyond the asymmetry through some cases. The first case is a 48-year-old female on regular screening since 2019. She came in 2022. The mammogram showed heterogeneously dense breast showing multiple obscured mass lesions. The AI show left lower inner quadrant area of high probability score. We recall this patient to do ultrasound. Ultrasound show extensive fibrocystic mammary changes with tiny left lower inner quadrant angulated mass lesion. Contrast show speculated lesion, left lower inner quadrant speculated lesion with multiple satellite lesion. Was the lesion present in previous mammogram? Have we missed before? We revised the previous mammogram in 2021, and unfortunately there is left lower inner quadrant area of subtle focal asymmetry and distortion, but was missed. The score was also high, about 54%. Unfortunately, we did miss the lesion because of the heterogeneity of mammogram. Pathology was invasive duct carcinoma grade 2. Another case, screening mammogram of 40-year-old female. She came 2021, and the breast also heterogeneous. There is left upper outer quadrant microcalcific foci, paleomorphic microcalcific foci. The AI was very high, 98%. The ultrasound show heterogeneous dense breast with cyst with microcalcification. So we didn't believe at AI at that time. This patient came in 2023. She was symptomatic with uni-orificial bleeding per nipple. It is a red flag. Mammogram, we compared the mammogram in 2021 and 2023. Unfortunately, there is a left upper outer quadrant area of focal asymmetry with progression of the overlying microcalcification. So it is developing asymmetry, as in the previous one there is a subtle area of asymmetry and distortion. The biopsy was mucinous with intermediate grade DCIS. Is that true that AI can detect breast cancer on screening mammography as early as 2 years before radiologists? We will answer this question. The ultrasound show a rather well-defined oval-shaped heterogeneous lesion. It is a mucinous carcinoma on ultrasound, and contrast show large area of heterogeneous non-mass enhancement. The last case, screening mammogram of 49-year-old female. She came in 2020, and there is left upper outer area of focal asymmetry. The AI was 0. We biopsied this lesion, and it showed the complex sclerosing lesion. It's a benign entity with no underlying atypia or malignancy. This patient came in 2022, and the mammogram showed the left upper outer quadrant asymmetry more apparent and seen as a speculated lesion in tomo and ultrasound. The AI show 17 abnormality score. So, should we rebiopsy this patient? Yes. And the rebiopsy also show complex sclerosing lesion with no underlying atypia or malignancy. Finally, advantages of AI. AI make radiologists more confident. AI increase productivity through allowing breast imagers to move faster through normal and give more devotion to suspicious cases. AI elevate radiologist burnout through, as it is a dear colleague who never get tired and has consistent performance. AI boosts accuracy through giving probability score of malignancy. AI support improved patient care through decreasing false positive and false negative results. At the end of the session, will AI replace radiologists? The application of AI is meant to enhance radiologist performance, self-confidence, and not to replace him. Radiologists are indispensable and way more valuable to be replaced by AI. So, AI and the radiologist are teamwork. Finally, I wanted to, I'm so grateful to my professor and mentor, Dr. Rasha Kamel, for the most informative and unique cases in presentation, and my dear professor, Dr. Suha Talat, for her supervision, our head of our unit. And finally, Dr. Sahar Salim, head of our department, for this prestigious conference, and thank you for you all. Thank you.
Thank you, Dr. Alaa, for very nice presentation. أنا طبعا معاكي بشكر الدكتورة رشا كمال والدكتورة سهى طلعت لأنهم فعلا أسسوا وحدة